want to introduce Dr. Simon. It's my pleasure to introduce Dr. Simon. He's a board certified specialist in physical medicine and rehabilitation whose practice focuses on electrodiagnostic medicine. Dr. Simon he's a published physician and an active member of several leading professional organizations, including the American Academy of Physical Medicine and Rehabilitation, the International Pain and Spine Intervention Society, the American Society of Interventional Pain Physicians, and the North American Spine Society. So we're very excited to have him join us today and to share his expertise and insight. Dr. Simon, would you like to unmute and introduce yourself before we go ahead and get started?
Yeah, hi everybody. I'm Jeremy Simon. I work at Rothman. I've been doing this stuff for like 20 years. I did my residency at Jefferson, which I hope you all strongly consider. It's a great program. So the residents work with me on a mandatory electrodiagnostics rotation and also an elective. I had three residents today. I know at least one of you, you work with me, Joe, when just on elective time, but I like to teach. I did a pain fellowship too, so I don't put that out there anymore, but I have a board certification in pain management too. And I just kind of been doing electrodiagnostics as part of my a career for a long time, and I always enjoyed it. And as I've gotten older, I've just liked spending more time with patients. So I've kind of given up the pain part of things and focused on basically clinical, like, diagnostics. So I enjoy the clinical exercise. Most of the people that come into the electrodiagnostics lab, there's sort of a question about what's going on. A lot of them are frustrated. Sometimes the symptoms are vague. A lot of physicians have limited time to spend with them. So what I enjoy doing is kind of spending time examining, using our brains to figure it out. It's exciting to see a lot of young minds get excited about this stuff. So certainly, if any of you guys have an interest in coming to Rothman, working with any of our guys or me, let us know. We'd be happy to have you too.
Yeah, that's awesome. So what today is going to kind of look like, just so everyone's aware, we're going to go ahead and have Joe start us off with the first paper. He's kind of going to give us like a brief overview of what the paper was discussing and kind of provide us some insight. And then after that, we're going to go ahead and transition over to Jonah, who will give us more insight on the second paper. And then we're going to open the floor to everyone and have Dr. Simon kind of facilitate the discussion as we all kind of just essentially just discuss the papers. And both papers today will be the same topic. It is on brachial neuritis, also known as Parsonage-Turner Syndrome. But other than that, we can go ahead and get started. And then Joseph, if you want to share your screen, yeah, you can go ahead and get started whenever you're ready.
Good. Yeah, I'm just gonna send you a request for it right now.
Oh yeah.
Awesome. Let's go ahead and share this
By the
one.
way, one of the authors is a former resident. So Dr. John Norbury is one of the former Jefferson residents. He worked with us.
Oh, let's share the other screen. Don't want you guys to see all my notes. There you go. No pressure there with that one then, Dr. Simon. Yeah, so you guys, I'm Joe. I got to work with Dr. Simon earlier this year. I can plug for that type of elective as well. It was a great time. I've only spent 2 days with him and I learned way more than I thought I'd ever learn on 2 days of PM&R. So great rotation, great guy, highly recommend it. Our article, or the assigned article for me, was on neuralgic amyotrophy, which is another name for brachial neuritis or Parsonage-Turner syndrome. Um, this was a brief overview on diagnosis, pathophysiology, and treatment approaches to neuralgic amyotrophy. And then you can see all of the journal findings there. Just making sure you guys can see just the PowerPoint, correct? Not my other screen.
Correct.
Cool.
Yes.
Cool. Thank you. All right. So learning objectives for this PowerPoint today. Just understand the clinical presentation and diagnostic criteria for neuralgic amyotrophy. Review the proposed pathophysiologic mechanisms and any etiologic factors associated with it. And then discuss the current management strategies and prognosis of neuralgic amyotrophy. So here's the scariest Halloween photo I'll ever show you. It's the brachial plexus. We have a lot going on here, and there's a lot of overlap with what we're going to discuss today. So I highlighted a few here that are the primary players with neuralgic amyotrophy. And I'll just refresh people. I know it's been a while since we've gotten a lot of brachial plexus practice. But if long thoracic nerve, you're thinking medial scapular winging with shoulder abduction. There's really no numbness associated, no sensory issues. The suprascapular nerve, there's a weakness in the shoulder with abduction. You're thinking the supraspinatus muscle, some external rotation issues with the infraspinatus muscle. And you kind of want to keep this in the back of your mind as we discuss later. But the effect, like mass effect of something being there and pinching on those nerves. We'll see that with our case today. The musculocutaneous nerve, you'll get some weakness of the elbow flexion and supination. Dr. Simon loves supination on EMGs. That's one thing I haven't forgotten since June is always make sure to relax. You guys will learn that when you do EMGs. But supination, biceps brachii, brachialis, coracobrachialis. You'll get some numbness of the anterior lateral forearm, as well as the lateral antebrachial cutaneous sensory, and an absent biceps reflex as well if you have a musculocutaneous nerve injury. Traveling down, you get to the axillary nerve, so we're down here now. You'll have weakness of shoulder abduction as well, and external rotation, effect of the deltoid and the teres minor muscles, and some numbness over the lateral shoulder as well. And then lastly, kind of an offshoot of the median nerve, you have the anterior interosseous. That's a motor branch of the axillary. And you'll have weakness with thumb flexion of the flexor pollicis longus, some pronation with the pronator quadratus, and then flexion of the distal interphalangeal joints of the second and third digit. So you have an inability to do the OK sign, and you'll see in a couple of slides what that looks like on examination. So I kind of wanted to paint this more as a brief case. So I kind of made up this patient scenario, and I'm going to ask for some audience feedback. So brace yourselves. But we have this 34-year-old male with no significant past medical history. Comes in today with sudden onset of severe right shoulder pain that woke him from his sleep 4 days ago. No trauma overuse, no heavy lifting, no fever or other systemic symptoms reported. And then on physical exam, he had minimal tenderness relative to the pain reported. There's no erythema, swelling, or warmth. There's active abduction, external rotation was severely limited by weakness. And there's some sensory loss over the lateral shoulder and forearm. So my question for the group is, you can type in the chat, you can unmute your mic and say it out loud. I'll give you guys like 30 seconds, but list off a diagnostic study or some labs that you would want to order and why. Think about it. So after like physical exam, what would be your first instance or first thing you'd want to follow up on? Give a vague physical exam here. There's some shoulder issues. I'm thinking it's a shoulder issue. My first thought process for imaging would be it's like pulling teeth. Is this what it's like every time, Dr. Simon, when you're giving these? Okay, so we order an X-ray. So somebody orders an X-ray, it's normal, nothing to find there. We can follow up, get an MRI on the shoulder. We can also order labs, and with labs, you're looking at inflammatory markers like CRP, ESR, all the stereotypical acute phase reactants. They're all normal. And then your autoimmune screen for labs too is negative. So you roll out labs, you roll out your X-ray, nothing's there. MRI shoulder shows a normal rotator cuff, and there's no joint effusion. So we'll get into this a little bit in terms of when to order an EMG and some nerve conduction studies. But essentially what you would be looking for is the denervation of those muscles along the distributions we were kind of talking about prior. So neuralgic amyotrophy, brachial neuritis, Parsonage-Turner Syndrome, all the same names. It's an inflammatory peripheral nerve disorder characterized by sudden onset, mostly nocturnal upper extremity pain, followed by weakness and atrophy. So as we saw with our case study, this is kind of the spitting image of what our patient was reporting. The incidence is about one per 1,000 patients. And the etiologies range. It can be idiopathic, hereditary, and then hereditary, you see mostly that autosomal dominant mutation in the SEP9 gene on chromosome 17 for all the biochemistry nerds out there. Anywho, it can be mediated, so it's been seen after vaccinations. post-infectious. It can be stress mediated after surgery or pregnancies. And the initial thought was that these symptoms would completely resolve in 2 to 3 years with conservative treatment. But it's not what we've been finding on in practice and in theory. So how do we kind of follow up this type of patient, this type of presentation? We kind of are looking for a good physical exam, and I know my school's harped on it. I feel like it's a really good tenet of osteopathic medicine, but just it's where medicine's going in general is having that really good physical exam and knowing what to look for right off the bat. So being able to do those different nerve distributions and started ruling out what muscle groups are going to be affected, what actions are going to be affected. And you want to tailor this exam to evoke as little pain as possible in these patients. So whether that starts with the visual inspection, and you can see here on this patient, like you can visibly see there's some differences between these two patient shoulders, as well as like the OK sign. There's visibly differences. So you're not going to generate too much pain for that. You can look for atrophy of the shoulder girdle, the scapular region, and the forearm. You can see where the sensory deficits would be. And mostly with neuralgic amyotrophy, you'll see patchy sensory loss along the shoulder and the forearm. You can start doing your manual muscle testing with the infraspinatus, the supraspinatus, your serratus anterior, deltoid biceps, keep going all the way down. And then there's been some conversation about whether to do a full brachial plexus evaluation versus like this 2 minute quick evaluation, which I have up here in the right hand corner. So if you know you're seeing certain things, you know which muscles you're looking for. Scapular ring with serratus anterior, so you're thinking long thoracic nerve, for example. And you want to look at it at rest. So see what your muscles are doing at rest versus when they're active. So for example, on this picture on the left here, it says A, your long thoracic neuropathy. So you'll see that the scapula deviates medially and has almost like this ropey characteristic to it versus a spinal accessory nerve, a neuropathy, where the scapula travels laterally from the patient. And then we start to get to the point where, okay, we're 3 months from symptom onset, we're 6 months from post symptom onset. When do we start ordering these EMGs and nerve conduction studies? They aren't pleasant. There's needles, and people get these shock sensations. They're minor, and it's like shuffling your feet on a carpet, and then you get a shock. So that's how it's been described. But it's still a somewhat invasive procedure. So when's the fine line between ordering this and then jumping on these symptoms so we can start treating it sooner so they don't have more long-term effects? And that's when the nerve conduction studies and EMGs were previously suggested to be 6 to 12 months post-onset. And there's other studies too with neuromuscular ultrasounds and magnetic resonance neurographies. And these have been found to find pathognomonic signs like the hourglass-like constrictions and denervated muscle groups on imaging, where you can see there's more of these chronic long-term changes that might not be as reversible if we caught it sooner rather than later. These hourglass constrictions, we'll see it on the next slide, but they are detectable on the MR end as soon as 3 days post-symptom onset, while on the ultrasound, it's 12 hours post-symptom onset. So if you're not ordering these types of studies like the nerve conduction and EMG, it's until 6 to 12 months after post-symptom onset, after you exhausted conservative therapy and it hasn't worked, now you're considering possible surgery. Like, is there room in place to get these ultrasounds and MRNs even sooner? And then you deal with the issue of, all right, is insurance going to approve of these if you don't go through all the proper channels prior? So on this top imaging, this is our ultrasound image. If you follow along where the arrowheads start to come down, you see this hyperechoic area, and it starts to find hypoechoic. This is where the nerve itself channel starts to get contorted slightly right here, where it starts to lip off. So that's you would see not exactly like an hourglass constriction, but it's torsion of the nerve itself, and that's the phrenic nerve becoming progressively hyperechoic. And then these three images on the bottom, it's a series all in the same. So starting from left to right, for A, with this T2 weighted MRN, you see this hyper intense area in the left upper trunk. And then as you kind of go through, now you start to see these hourglass constrictions in the left suprascapular nerve and the upper trunk. And then you go to the last one, and you start to see this hyperintense signal of the lex axillary nerve as well. And if you travel up just a little cephalad to it, you'll see this hypoechoic. You see it's a change in intensity. And that's what we're trying to find on this MRN. So what does this mean in terms of our clinical implications in terms of acting upon these studies? It really is the sensory and tactile feedback cues over strength training in terms of conservative management. We're trying to make these patients move properly in the proper positioning instead of just being able to muscle through something, because that will just create further compensations and worsen the issue. So one of the tests I found while I was researching this article and looking into more stuff is the scapular assistance test. I have a video on the next slide if we get to it. But essentially, it's a provider puts their finger on the inferior angle of the scap and then kind of gives a tactile cue as the patient abducts and brings their shoulder over or arm overhead. You can also use like taping. I've seen a lot of people use the kinesio tape, some mirror visual feedback, and some offline video instruction of like coaching points to kind of reinforce proper movement mechanics of that shoulder. Dry needling to kind of break up that fibrotic tissue and help with that acute like increased range of motion, as well as the proper coordinated movement of the shoulder. And then there might be some role for OT as well to really emphasize the use of mini breaks to prevent overuse of the muscle groups affected. Interdisciplinary team, if this issue goes on for an extended period of time, usually involves like a neurologist, a physiatrist, so PM&R, PT, OT, some room for RT and pulmonologist as well, which I found interesting, and then the psychologist. I mentioned the RT and the pulmonologist because the phrenic neuropathy that we saw in the ultrasound earlier occurs in about 7 to 8% of these patients, and you should be able to screen for dyspnea, orthopnea, and daytime somnolence, as well as excessive fatigue and sleep disturbance. And you're seeing, because of the phrenic neuropathy, that it's controlling or they're not able to control their diaphragm more or well. So you might want to consider for a spirometry test to test the forced vital capacity as well. Acute pain, this article specifically, but then upon further review mentioned, do we treat with NSAIDs versus steroid taper versus your neuropathic meds such as gabapentin, your TCAs, and carbamazepine versus the giving an IVIG if it's more serious or refractory to those acute treatments. And then down the line, and I'll mention this a little bit more on the next couple slides, but is surgery recommended? Do we want to take it that far? Do we have to let it get to that chronicity point where we're not jumping on these symptoms sooner rather than later in terms of getting the ultrasound or MRN sooner? But surgery would be is currently recommended for mild to moderate constrictions with a resection and grafting for a more constricted section upon further review. We can skip over this for now, just for time's sake. But then reiterating the surgery. So one of the studies I found interesting within this paper itself was a very small study of 24 people. 11 people got surgery at about 12 months post-symptom onset. 13 stayed with conservative management, and about 82% of that surgery group had significant clinical recovery when they graded it, compared to 23% of the conservative management group. So small sample size, different surgeries. You can't really monitor all of the different conservative management that was done by the 13 people. But it's still worth noting that this is where kind of the mindset's going with how do we address these chronic issues if patients are refractory to all of the conservative management, or the timeline gets too extended and symptoms become more permanent rather than temporary. So at the end of the day, the initial period of conservative recommendations or initial recommendations is trial the period of conservative management to allow for that spontaneous axonal regeneration. And if there's no improvement, then pursue those studies to see if you see any of these hourglass constrictions. And then get the surgery by 6 to 12 months post onset if symptoms are still refractory to conservative management. So key takeaways: neuralgic amyotrophy is an inflammatory peripheral nerve disease characterized by sudden onset nocturnal upper extremity pain followed by weakness and atrophy. Physical examination is key. Too many times in clinic, I think we get a little bit complacent in skipping over things or not doing things by the book. But sometimes it could be our biggest like asset in terms of sometimes the labs, sometimes the imaging, whether it be time or just not knowing which to get, might not point us in a certain direction. It might even confuse us. But our physical exam can lead us in the right direction if we just trust it. Um, Letting it kind of dictate which neuropathies affecting which muscle groups, which sensory losses were is associated with the muscle group, and that could also guide the further treatment and diagnosing of this disorder. And then really reinforcing when we're treating these patients with sensory and tactile feedback to reestablish the movement patterns. And then pain control for more acute symptoms and recovery to reinforce patients being compliant with the conservative management. We know acute pain kind of takes away from wanting to go to the physical therapist or wanting to follow up with OT. So we want to try to make sure our patients are on board for that recovery process. And then here are my references. And then if you guys have any feedback, I can put this up again at the end. But we'd love to hear your feedback. And that's it. Thank you for your time.
Great job, man. I'll make some comments if that's okay. I thought you did a great job. One of the things I'll say just kind of from the jump, I don't know, I'm not going to have you guys all raise your hand, but I never heard of this condition when I was a medical student. I had no clue, never heard of it. And what I'm always surprised by, not so much anymore, but a lot of attendings have never heard of this. So a lot of times when people end up getting diagnosed with it, it's almost by accident. People will describe this oftentimes as the worst pain that they've ever had. I've had women who've had three kids tell me that childbirth was not as bad as the pain that they had, and it freaks them out. I mean, a lot of times they'll end up in the emergency room and they could tell you, like Joe was saying, like, oh, it woke me up at 2:36 a.m. I felt this stabbing, horrible pain, often in the shoulder girdle. It's bad enough to lead, a person to go to the emergency room. And then interestingly, in the emergency room, a lot of the doctors don't know what it is. So they'll get, there'll be a thought that maybe it's a pinched nerve in their neck or they tore a rotator cuff muscle. Oftentimes they'll get kind of bounced around. And so just a lot of doctors have no clue what this is. So the reason I picked this article was because I just wanted to introduce it to you guys, especially if you're going to rotate through an electrodiagnostics lab, because if you're there, you're almost certain to see it. Um, they often end up seeing shoulder surgeons, and what can happen a lot is people will come in, the pain lasts often for a few days, and then the pain goes away, and they're typically left with really bad weakness. One of the things that you can often distinguish between your average run-of-the-mill pinched nerve in the neck versus someone who's got Parsonage and Turner is that the degree of weakness is often pretty astounding. They'll get atrophy, like which you don't usually see in most radiculopathies unless you have a humongous disc herniation, and often if it's hitting more than one nerve, because you guys learn, oh, your bicep is supplied by C5 and C6 musculocutaneous. Let's get C5 and C6 in it. But this is a peripheral nerve, so it's the nerve that's actually, as it's going to the muscle, gets severe axonopathy, and it's motor predilection. So just like Joe was saying, the sensory symptoms, they don't always get them. They'll kind of get these weird, kind of tingly, paresthesia is what we call it, and they're not often in a dermatomal distribution. They're really not bothered so much by the paresthesias. It's really the freaking out about the pain and then the severe atrophy that follows it. So I'm one of these Gen X people that got diagnosed with ADD later in life. So if I get too chatty, it's a medication issue. So just I don't know what your timing is, but I want to make these points real quick. Just tell me if I'm going too long. Um, so like I said, it's got a predilection often in the shoulder girdles, but it's got a weird thing where it'll hit nerves that you go, why the hell is that nerve affected? Why would your long thoracic nerve be hit? There's not like a compression that you would typically think of. It's rare to have a tumor hit your long thoracic nerve. Um, the hereditary variant, I just want to make a point. So there is a hereditary version of this, and one of the differences is that usually if you get Parsonage and Turner, you're one and done. So you had it, it sucks, but you don't get it again. If someone has it again, that typically suggests that it would be, probably a hereditary variant. And it's also rare, but it can happen that it's bilateral. Um, it could also follow weightlifting. And that freaks me out because, especially as I get older, there's data that weightlifting as dementia prophylaxis, but it's usually an excessive amount of weightlifting. So if you guys try to kill it at the gym, not saying you're going to get Parsonage-Turner, but it can happen. What I say is like it's sort of an unusual amount. So I've seen patients like who are pretty sedentary that end up like I had one lady that helped her daughter move, and so she was carrying all these boxes, and then like a couple days later, she had this same presentation, horrible pain in her shoulder, followed by atrophy with the EMG. And I saw appropriately there was a comment from Michael that said that, you would consider an EMG. The one thing I'll put to that is that it takes a while, and you guys may not know this. I wouldn't have known this when I was a med student, but for the EMG findings to show up, it typically takes at the minimum 7 days for what are called fibrillations and sharp waves to appear. So one of the points of the article is that you do want to have an early diagnosis because these people get kicked around a lot. And one of the things that happens is like, oh, you probably strained your rotator cuff. Let's send you to physical therapy. The problem with that is it's believed to have an ischemic component to this. A lot of why you get the axonal loss is it's a vascular insult to the vasa nervorum. So if you start stressing an ischemic nerve, you can actually make it worse. So if they don't have a diagnosis, you can get an overzealous physical therapist or an overzealous doctor that's telling them to do too much and actually is counterproductive. Um, the other I also the other thing too is they had you briefly I'm picking nitpicking here, but like when they had this chart in there that you presented, and I agree with you, what you do on an EMG, and you'll see this, depends on the patient in front of you. So there's things that you might do at a minimum. There's, sometimes you get people that can't tolerate it. But what the danger is if you don't screen properly is sometimes like we see this with you guys. I don't know if you know about post-polio syndrome, but people who've had polio, they may have like an atrophied limb and the other leg was fine. But as they get older, they may have had a milder hit that was subclinical. And when they get older and they have normal like neuropathies and things that develop, all of a sudden they get this, the side that was bad gets worse, and the side that they didn't have, they start to get symptoms in it. Why is that? It's called post-polio syndromes. That can sometimes happen where they have more going on than what would lead you to believe from just your history and physical alone. The other thing, couple other questions, and I'll promise I'll stop. The ultrasound is a little bit overblown. It's a very operator dependent. A lot of the people that do it, depending on who you're sending to, don't know a lot about Parsonage and Turner. But when you do see the hourglass, the findings that you see, that does and the constrictions around it, that does often portend to a bad prognosis. The other thing is the practicality of getting an MR neurography, the magnetic resonance neurography, is it's a long protocol. So we've tried to get it. The machines are easy, but sometimes they have to program and it could take them 3 hours. So depending on the place that you're sending them to, they might say we don't do it because they can't bill for for 3 hours for that one patient, because it's clogging up the machine. The other couple, two extra points, and I'll stop. Oftentimes, what way these people end up coming to us, especially from like, say, it's a family doctor or someone that goes, "Oh, I think you have a rotator cuff tear." So they may actually go and get an MRI of their shoulder, and what it won't show is a rotator cuff tear, but it can show edema, like big bright edema on the T2 images that you see, like Joe was showing you, but in the muscle. So it's a sign of denervation, and what will happen is on the report they'll say suggestive of, like if it's in the infraspinatus and supraspinatus, for example, they'll say suggestive of a suprascapular neuropathy or parsonage and Turner, neuralgic amyotrophy. So then they go on ChatGPT or whatever you do these days, and they tell them, oh, you should go see someone to get an EMG for this. So they'll sometimes come in that way because another test led them. And that's all I have to say. I don't know if you have any questions for me before you go on to the next one.
So we were actually just gonna go ahead and move on to the next one, and then we'll leave it for like an open discussion right after the next one. But yeah, Jonah, you can go ahead and share your screen.
You guys see my screen? I think it probably looks weird right now, probably.
Yeah,
And
we can see it.
then wait from start. All right, cool. Can you guys still see everything? Oh, can you guys still see
Yeah,
everything on my
we can
Yeah,
screen?
we
see
can
it.
see it. We can see it.
All right, cool. So, hey everyone, my name is Jonah. I'm a third year here at PCOM. And the article I chose was basically predisposing factors for an incomplete spontaneous recovery after Parsonage-Turner syndrome. So basically, after Joe's article, we learned a lot about what Parsonage-Turner syndrome is, just how the presentation is, and kind of what Joe kind of talked about and kind of alluded to is sometimes you may need surgery, but also sometimes conservative management will lead to a either a complete recovery or an incomplete spontaneous recovery after a patient suffers from Parsonage-Turner syndrome. So that's basically kind of what this article dwelled into. So let's go on from here. So first off, I'm going to start with the case that I actually saw on my PM&R rotation earlier this summer. So basically, woman, early 50s, came into the office because she basically just had a scheduled EMG here. So about 2 months before this office visit, she experienced what she called a 7 out of 10 sharp, kind of tingling, pinpricking type sensation in her right upper back area and her shoulder area. The pain, like Dr. Simon was kind of mentioning, started as she woke up from bed. She said that it was constant pain. Nothing really helped. She tried taking like Tylenol, ibuprofen, those didn't touch it. She kind of basically what she told me was she just kind of tried to tough it out until basically she went to sleep. And then after that kind of initial 24-hour period, she realized that she had severe weakness in that right shoulder. So the weakness kind of led to her well, going back a little bit, um, one thing my attending from PM&R always told me to do is always make sure, especially with arm complaints, make sure you know what they do for a living and then make sure you know what hand they write with. So she had just moved to Delaware. She just got a new job in the office, like a state government office. So she was kind of stressed after moving there. She kind of recently moved, did some moving, stuff like that. So she was really worried about whether this arm weakness was going to affect her starting her new job. So when she experienced this weakness, she went to the ED because she wasn't really sure what was going on, and she was afraid she might have been having a stroke. Um, at the emergency department, she said that they did all the testing. They realized she wasn't having a stroke. I believe she kind of got a little bit of a runaround, but someone did refer her to get an EMG at my attending's office, which is why she kind of ended up there. So basically, it took maybe like 2-ish months. So she went from kind of a flaccid, just like almost no real muscle strength in that right arm, right shoulder area, to gaining some strength. She was able to start her job. She kind of was able to start her job. She mentioned that she was kind of just doing lighter work. She told them what was going on, and they were kind of accommodating as well as they could. But she still feels that she has some weakness in that arm that's really notable. It does affect her ability to work a little bit. She's getting through it, but she's not complete. And she's not completely back to normal at this as of that visit that we had. So when I got in there and kind of saw her, she was relatively healthy, no significant past medical history, didn't have diabetes, hypertension, any chronic conditions. One thing I really like asked her was if she was tended to eat like a balanced, healthy diet. I was kind of like worried about like a B12 deficiency apparent potentially. But everything's in terms of past medical history for her seemed relatively fine besides you know, this current condition with her shoulder that she had. She did endorse that she got sick right when she moved over to Delaware, but she wasn't really like, she didn't get tested for anything. She was just like, oh, this is just an upper respiratory illness, just like any other. Um, but that's basically all that she was able to kind of report in terms of new things that have been happening recently for her medically. So I did all the muscle strength testing in the shoulder and arm. Everything was mostly normal. She did have some pretty good weakness in her right deltoid. It was very easy to break her resistance against gravity. So I did tell the attending that, and he kind of agreed with me on that. Other than that, range of motion in her shoulders were normal. I did some of the special testing for the shoulders, like the empty can test. Um, None of those really elicited any real pain or like positive findings. I did Sperling's test, which was negative, and also I did Tinel's and Phelan's. I just kind of was throwing everything I kind of knew about the arm at her before my attending came in and did the EMG. So he came in, did his EMG/nerve conduction study. He did feel like he saw damage that was consistent with Parsonage-Turner syndrome. When I told him kind of her story and what she was reporting, he really like that's kind of what he kind of leaned towards with the diagnosis. Also on EMG of note, he didn't see any evidence of like cervical radiculopathy, which was also potentially on the differential for her. So he basically felt like she was getting really better relatively quickly. So he did prescribe physical therapy, and he felt like she was going to make a full recovery. But she is probably going to be monitored throughout the next year or so just to make sure that everything's fine with her. Everything ends up fine with her. So had some stuff on the background of Parsonage-Turner syndrome, also known as brachial neuritis. Um, we don't really know the cause, but it is associated with some infections, trauma, surgery, vaccines, basically a lot of like stress and autoimmune type responses. So it is a clinical diagnosis with a particular emphasis on the order of its symptoms. Typically, you will have that like sharp pain, and then it'll go into like a flaccid paralysis, and then a slow but kind of slow recovery. So going on to recovery. So the recovery period is it's extremely varied. Um, Typically, a lot of articles say that it lasts for less than 1 year, but for some patients, it doesn't resolve as its own. They may have only a partial recovery, or they may require surgery or extensive physical therapy, or it may last for like up to upwards of like 3 to 5 years instead of just lasting for like less than one. So, in terms of treatments, they listed that there's no standardized treatment plans made for Parsonage-Turner syndrome, but some things that patients may use or doctors may use to treat Parsonage-Turner syndrome include NSAIDs, corticosteroids, physical therapy, eventually potentially surgery, basically just a lot of supportive measures. So the purpose of the article that I kind of went over was to review and assess the demographics, the presentation, and outcomes of Parsonage-Turner syndrome, and identify any potential predisposing factors for a patient having an incomplete spontaneous recovery. So basically, this was a retrospective study that was done at Mayo Clinic Rochester. So they went with a cohort of patients, all patients who had Parsonage-Turner syndrome at Mayo Clinic Rochester from January 2002 all the way up to January 2024. The primary outcome that they measured was muscle strength recovery. So they used the modified British Medical Research Council score as their standard of muscle strength. So I wrote here just the first three grades here. So grade 5 meant a full recovery equal to the opposite side. Grade 4 meant a mild recovery but unequal to the opposite side. Grade 3 was a full active motion against gravity, and grade 2 and less. We're in grade 2 and 1, we're just kind of less than that. Um, so they placed patients with scores of grade 5 and 4 in the recovered cohort and patients with grades 3 or less in the incompletely recovered cohort. So variables that they looked at in this study included age, sex, what hand they use, what whether there was both sides affected or just a single side affected, what their occupation was, family history of potential neurologic disease, comorbidities, whether this is a recurrent Parsonage-Turner syndrome, the presence of pain before, and the type. One big thing that they looked at was the type of predisposing event that may have triggered the Parsonage-Turner syndrome that they found in their charts. And they looked at a few other things too. So the types of predisposing events that they looked at included infections, strenuous activities, trauma, vaccination, and surgery. So in terms of results, so they had a final data set of 100 patients who met all the inclusion criteria. So out of 100 patients, they found that 65 met the criteria for a full recovery, being that grade MRBC's grade of 4 or 5. So the group of patients that fully recovered spontaneously tended to be significantly younger than patients that didn't. They also found that patients that fully recovered had lower rates of the bilateral Parsonage-Turner syndrome involvement. Typically, trauma was associated with a greater rate of spontaneous recovery compared to other predisposing events that they've listed. Um, so they also typically, patients who had a full recovery typically had a lower number of total muscles involved. On Parsonage-Turner syndrome, and patients who only achieved an incomplete recovery typically had more involvement in the hand and wrist, while patients who had a complete recovery typically had more involvement in the shoulder. So with the hand and wrist, they kind of mentioned that the distal having distal atrophy may potentially just be kind of indicative of a more severe disease course. Whereas just the proximal atrophy may be kind of a little bit more of a symptom, less severe symptomology. So basically, they found about 60% of patients who suffer from Parsonage syndrome experience a full spontaneous recovery. Um, Key factors that may predispose a patient to having an incomplete spontaneous recovery include increased age, bilateral muscle involvement, a greater total number of muscles affected, and the presence of symptoms distally in the hand and the wrist. So, trauma as a predisposing factor was found to be associated with better outcomes compared to infections, surgery, strenuous activity, and vaccinations, which I thought was really interesting. Some of the limitations of the study that they listed include that it was a single center retrospective design, so it may not be the most generalizable study in the world. And they did note that they had a lack of information on any physical therapy regimens that the patients were on, just due to I guess like medical records, it was kind of hard for them to figure out what exact physical therapy regimens that all their patients were on. So those were kind of some limitations that they noted for this study. And that is it. So I'll stop sharing my screen.
All right, so thank you so much, Jonah. So yeah, so now we were just gonna open the floor to everyone. Feel free to drop your questions in the chat, or you can go ahead and unmute. And then I can actually go ahead and start us off with a question. So Dr. Simon, I was kind of curious. So in regards to that second paper, like the authors were suggesting how trauma cases recover better because they're more often like focal and not immune mediated. But I was gonna ask you, do you think like maybe immune modulating therapy might like offset that difference, or like what's the idea behind like how trauma-related like Parsonage-Turner syndromes have better recoveries than more of those idiopathic cases due to like vaccines or infection or other like sporadic cases?
Yeah, I think probably the immune response is a little bit more muted in a trauma case because it's believed to be. I mean, again, it's one of the interesting things, and why I think it's good to present this is because it's really not that excessively clear what is causing it. So, as Joe had said in the previous paper, like IVIG, like and other immune therapies, plasmapheresis, and things, it's unclear whether they really help or shorten the course. Part of it is because I think it's hard. A lot of times, these people don't get diagnosed right away. But probably my take on it would be that it's probably the trauma, like is um, sort of less of a immune kind of stimulant than something like a vaccine or an illness. Um, that would be my 2 cents on that. Um, will it, I mean, I think that's the way this is going. If I think the big thing, and why I think it's important for you youngsters to know this and have your antennas up, is that you see even like this person that Jonas saw in the clinic, they kind of ended up there circuitously. They're what's the heck's going on with this guy? Someone goes, I don't know, get an EMG, which a lot of times when they come to us, then it's to emphasize again a clinical diagnosis. But yeah, I mean the sort of overarching idea is that it's immune modulated, and that would probably be the best way to sort of focus some sort of disease modifying agents for it.
Okay. Thank you, Dr. Simon.
I had a question, and I guess it's just more general, and I couldn't really necessarily find it in the paper. Is it typically associated with other autoinflammatory or autoimmune inflammatory conditions? Like if someone has something like Hashimoto's or some family history of it, are they more likely to have to be worried about something like this, or is it
Yeah,
like
that's
we?
a very logical question, and it's not. I had a patient last week with Parsonage and Turner who here's an interesting one. He had a neck operation, right? So I'm looking at it and I'm like, oh, they couldn't figure out why this guy on the opposite side, about 8 days later, woke up middle of the night, severe pain, in the shoulder girdle, followed by really, really bad atrophy, no autoimmune history. He's in his maybe I think it was like 50, 58, 59, something like that. And like severe atrophy. I mean, kind of really freaked out. They re-MRI'd his neck, nothing in there. There's something called this is beyond the scope of today's talk. There's something called a C5 palsy, which can happen after, I don't know if you've done any spine surgery or had anybody with spine surgery, but sometimes you can get from some cervical decompression, a C5 palsy, which could mimic in a way Parsonage and Turner, but yeah, there's no data that would say like, oh, if you have lupus or rheumatoid or whatever, Hashimoto's, like you said, that you're more or less likely to get this.
Fair. Yeah. I even asked too. I have a family friend who he's a he makes cabinets for or runs a company that makes cabinets, and he did it for a very long time as a carpenter. And he had adhesive capsulitis in his dominant shoulder, and then had some limited range of motion, among many other things, and a lot of pain in that shoulder. And then randomly, about like 2 years ago, he started having like similar symptoms that sound similar to what I did before reading these articles. I had never heard of this syndrome either. But it sounds similar to this, if I'm being completely honest. And he had gotten, I mean, God knows how many imaging studies in every which way about the about having it, and it was like scary for him. And on top of it, which made matters a lot worse, he's fine now, but he had a stroke about like
Oh.
2 or 3 months ago, and they found a patent foramen valley, and so it's kind of been shouldered back to even think about something like this. And so, before that whole thing happened. And he's been recovering fine. He doesn't have any uh, ongoing symptoms uh, of anything going on now. But they were starting to look into the fact that he has a really long history of, or long family history of autoimmune diseases, and like on both sides for him. And so it sounds like they were possibly looking for something like this, but they were pretty convinced that it was somehow linked to that. And I was wondering if that was at all an explanation, but I guess not at all.
Not I mean, there is some for the hereditary variant, like Joe had pointed out. There's a there's chromosomal and gene linkage to it. So in the sense, I don't know if that overlaps. There's some overlapping conditions that we see with neuropathies, but not with just like your run-of-the-mill autoimmune guy that you guys get pounded into your head in medical school. It's not those things.
Yeah. Yeah. I guess the other question I would have in reference to this too is because you said some of it has been linked with some microvascular changes
Yes.
in some way. Is that like in reference to like atherosclerosis you're meaning, or to other
Yeah.
clotting?
Um, it's vasculitis. So it
Oh,
is
okay.
not. Yeah. So what happens is it's like where they're it's unclear exactly what um you know the sort of what where everything is being attacked. So one of the business with it is is ischemia to the nerves from an autoimmune attack and vasculitis. So not from the from like a
I see.
poor circulation, but from just vasculitis.
I see. That makes sense. Thank you.
Um, Couple other quick comments too. So if you guys like, so again, it's a clinical diagnosis. So hopefully this kind of gets put somewhere and you can pigeonhole if you're in the clinic. The other thing I'll tell you is, if you probably learned, I mean, if you want to be a wise ass or something like, if you're on a if your attending says, give you what do you think this is? You could say lupus or syphilis, and you can almost always say, oh yeah, that could be, But a lot of these upper extremity things, can be Parsonage and Turner, but what because you get pain and weakness and things, you tend, as I mentioned, to not get really the numbness with it. But if you do musculoskeletal, EMG, sports, or pain, this will come into your office at some point. So you just have to have your antennas up because again it's usually self-limited, but what can happen is they get misdiagnosed, they can get inappropriate tests, sometimes inappropriate procedures. Um, Sometimes they get put into therapy too early, they can make it worse. So I just want to make a point of that. The other point I want to make is likely the reason why the hand and wrists have a worse prognosis is, and we see this with radiculopathy. You guys are familiar with that term, I presume. Radiculopathy is like a problem with the nerve root in the spine, right? So then people, if you have a foot drop, where you have like a bad L5 radiculopathy, the nerve has to regenerate and go from the anterior horn cells and the site of, through the site of injury all the way down to your foot. So oftentimes by the time the nerve would reinnervate down through those endoneurial tubules, they've collapsed and the muscle's atrophied, so it has no target, so people can have permanent nerve damage or a permanent foot drop. So if you have distal muscles that are affected, Parsonage and Turner affects they call it brachial neuritis. It's in the brachium, so it's got to come all the way down to the hand and wrist, and they get bad atrophy. Like one of the things when Jonah, when you were presenting it, I'm not sure if you remember or if it was emphasized. Do you remember if that guy had the person that you described, who was a woman, had atrophy, and was it in the deltoid? Was it like an axillary neuropathy that you think, or do you know what it actually was?
Um, yeah, she had like pretty notable like atrophy in her right deltoid.
Yeah, because 4 out of 5 is pretty darn good for Parsons and Turner. So she probably got hit with a relatively mild version of it. But if you had, a lot of the ones that we see at Rothman, I mean, they're like skeletalized. Like the muscles, like you see like in that picture, like you'll see the scapula, like you'll see it. It's just completely atrophied. So if you have that in like your flexor pollicis longus and that muscle's kind of really atrophy like that, then the nerve has to come it just may not have much to get to when it gets there, and it might just not be able to recover. So those were just the other two things I wanted to mention.
So does anyone else have any last minute questions that they would like to ask?
Hi, my name is Rohit. I just had a quick question. I think in the first paper they talked about like moving, I guess treatment plans away from like a pure strength model. But I wanted to ask like, what would that like look like? How would that practically work?
I guess, answer that. So, some of the things that so let's use the example of what we often see, which is scapular winging. So, for you guys, when I was in med school, like they would, when they give you the mnemonics, there wasn't a great mnemonic for the long thoracic nerve. So it was rose. We just would say roses are red, violets are blue, and the long thoracic nerve supplies the serratus anterior. That's what our anatomy professor told us. So if you see somebody with really bad scapular winging, um, so what the therapist will often try and do is they'll say, okay, let's work on scapular strengthening and like stabilizers. So they start having them kind of go like this because the serratus anterior, you go into forward flexion like in the sagittal plane. So they'll have you go like against the wall and do these progressive strengthening things. What you don't want to have happen is one that could hurt it. So, but you don't want to have them to get like the adhesive capsulitis, like Michael's, acquaintance that he had, and also what can happen. I think they mentioned this in the first article, but you can sometimes get the nerves can kind of go berserk and they start sprouting into different places. So you can actually get like these dyskinetic movements where it's kind of like, you go to move this way and your arm goes like that because it's kind of reinnervated a different muscle. So what they do is some of it is K-taping. Some of it is like kind of just doing scapular, like, like assisted scapular mobility exercises so you don't get a frozen shoulder. Some of it is modalities and stretching. So, and then they progress it. Especially if you're this is if you're catching it early. If you're fortunate or smart enough to catch it early, then you start with that would be kind of like the phase one physical therapy. As the pain improves, so presumably the ischemia is better or is resolved, then you can start to progress to strengthening exercises, and then that would the strengthening exercises would be the the both the antagonists and muscles as well, but also strengthening.
Thank you.
So yeah, so that concludes our first journal club. So thank you all for coming to our first journal club this year. So moving forward, look out for future journal clubs. We're gonna try to have one a month. But yeah, for now, if we can just all give a round of applause to our two presenters, Joe and Jonah, and Dr. Simon for joining us today and providing us with all this insight on Parsonage-Turner syndrome. But yeah, other than that, we're pretty much done for today. And then I was gonna ask if Dr. Simon, if you can just stick back just for a minute or two. But yeah, everyone else, you're good to go. Thank you so much for joining us today.
Thank you guys.